औषधम ततः कर्म पश्चात ज्ञानपूर्वम समाचरेत. Acharya Charaka very clearly in detail explained regarding why we should examine the patient very thoroughly. After that only we should write the prescription. Before writing prescription and after examination, there is an intermediate thing what we should do is writing the diagnosis for our confirmation of diagnosis of the disease what we have diagnosed. So investigations are a mode of roga pariksha. After rogam ado pariksheta, the first and foremost point what Acharya said, rogam ado pariksheta, the first and foremost thing is to examine the disease and the patient. Among examination of disease, after nidana panchakas, the second thought of presentation is second thought of understanding the disease is writing the investigation very properly and accurately. So what are the investigations and investigations why they are needed? Are not compulsory to write, or is it compulsory to write? And history taking and clinical examinations are sufficient or enough? By doing this only can we diagnose a disease? Is it compulsory or not compulsory? But as a practitioner, as a clinician, it is prime duty of the practitioner to write the investigations very correctly for the purpose to understand or to make perfect diagnosis of the disease. So what is the writing investigations for the purpose of diagnosis, which is confirmatory diagnosis, which can inclusive or exclusion of disease? Say for example, we are getting writing for different investigations for fever. It may be typhoid, malaria, dengue, and chikungunya. Even though all complaints are presenting with fever, but the presentation of fever is different. So for our confirmation, it is prime duty of the physician is to write the investigations for our confirmatory diagnosis and monitoring the patient by the disease and treatment. By knowing the investigations, in which stage the disease is present and what the treatment protocol can be practiced, that can also be understood with the writing the investigations. And the baseline establishment, we can establish what the treatment can be planned prior to the treatment, what must be treatment must be planned, that is to be understood by writing the or knowing the investigations properly. So let us see few cases scenario how they are representing in our clinical practices. Say a patient presenting with fever, abdominal pain, nausea, vomiting, loss of appetite, anorexia, high colored urine, and patient complains that history history of traveling is present. On examination, we are expecting icterus, that is plus, tender liver, and very mild enlargement in that we call hepatomegaly. This is one case of presentation. Second one, a patient presenting with abdominal distension, nausea, vomiting, loss of appetite, anorexia, high colored urine, swollen legs, blood in stool, vomitus, or patient may complain vomitus. On examination, icterus plus, gross ascites, enlarged veins. On abdomen examination, there is a enlarged veins on the abdomen. Third one, a patient presenting with severe itching, greasy, pale stool, lot of loss of appetite, anorexia. Past history of gallstone is present. Patient once said like that. On examination, icterus and scratch marks. A patient presenting with severe tiredness, weight loss, and abdominal pain. On examination, pallorness is present, mild icterus is present, and splenomegaly. By looking these four presentation, we can come to the conclusion, or we can say that a patient may be suffer with some of the liver disorder. Because of almost all, there is a left hypochondric region tenderness is present, or patient may complain different condition. So we can think of the patient may be complaining or may be situated to the liver pathologies. So what the LFTs, or what are the indications that, see, the biochemical analysis of LFT, liver function test, or liver pathologies can be understood that bilirubin total, bilirubin direct, these are the presentation, SGPT, SGOT, alkaline phosphatase, gamma glutamine transaminase, serum total protein, these are the contents. So see, there are four presentations what best we can study. This is how the presentation will come to the after writing the investigations. So if you come to the first investigations, there is a increase in the SGPT and SGOT. 2009-22 and 4222. This is what the present is presenting. This is direct hyperbilirubinemia where there is an increase in the SGOT and SGPT. So this is how in this condition SGOT, SGPT are normal, but there is a bilirubin level is increased. So there is a indirect bilirubin is increased. And the third one is here. Again there is a ALT is increased and AST is also increased there. So in this in the fourth presentation, total bilirubin is 13 and AST, ALT increases, ALP also increases. So this is how the presentation of patient, even though complaining of hepatic presentation, how the change in the different laboratory investigations. To understand this interpretation, a practitioner must know why LFTs are needed to understand or what to write. So, with this brief introduction, let us introduce to the subject proper. Liver is a major organ in maintenance of our homeostasis, which is made possible by the multitude of functions it caters. Thus, to understand its disorders, which are many in number, groups of tests are clubbed together and to form liver function test. Liver disease accounts for the approximately 2 million deaths per year worldwide. Then, as we studied in case of anatomy, liver anatomy first year, this is how the liver functions or the liver bile juices start secreting. Portal field, portal venula, bile ductule, hepatic arteriole. From that, the liver secretes the functions. The Kupffer cells are the responsible for the action of phagocytosis, endothelial cells, and space of Disse from the collection. From there is a entry of to the central sinusoids. Then this is the cross-sectional study of anatomy of liver. This is how the, see, we can see the, this is how the bile canaliculi, there is a 1, 2 and 3. From these only the secretion of bile juices will take place. From this there is a directly linked with the system. So what functions liver does? We all know n number of functions are carried out by the liver. Among them there are few are listed. One is metabolic condition. It can metabolize carbohydrate, protein, fat and bilirubin. Storage, wide variety of functions. So it stores everything. It stores carbohydrate, protein, fats and also some glucose, some minerals, some everything can be stored in the liver. Synthesis, there is a numerous synthesis, especially plasma proteins are the more synthetic activity of the liver there. There are some excretory functions. Bile is the major excretory function of liver. It also does hemopoietic and hemolysis. So as we are studied in case of Ayurveda, mool of Raktavaha Srutas is Yakrit Plihacha. So it acts as a hemopoietic system and also act as a hemolytic system. It also does detoxification. Whatever the overdosed or whatever the toxic material entered into the body, that can be detoxified through our liver and that can be expelled out. And phagocytosis, it is also having capacity to kill the some of the bacteria or virus which are entered to the our bloodstream or the liver condition. Others, there are a number of functions also contributed by the liver organ. Then what is the, before writing, before doing examination, there are something very important to know about history. First and foremost is age of the patient. As we know, there is a physiological and pathological jaundice in neonate. From that day, the third day onwards, jaundice starts presenting or the liver starts functioning, showing the pathological variation in the human body. So from the physiological and pathological jaundice from that age to last, patient may end up in the alcoholic liver disease or liver cirrhosis or liver cancer. From this, from the physiology of jaundice to the pathology of liver, whole system can be comes under age of the patient. So residence where he belongs to, there are some diseases that can be spread through endemic areas like rural Maharashtra, Shimla and Kerala. They are more prone and they have noticed more for the hepatitis diseases. Then traveling history to the endemic areas. Patient may having businessmen, they travel to the endemic areas. They also met with unfortunately or with the sexual activity also, there may chance of spreading the hepatic disorders. during blood transfusions before 1990 there is no proper screening of the some of the liver disorders like hepatitis. After 1990 if the person blood transfusion is there, that can be clearly tested and transfused. Unfortunately, with IV intravenous or intranasal drug abuse, sexual practices, anal sexual practices unprotected with the unknown or multiple sex partners with infected person, family history or family members can also be having chance of infecting the our liver system. Then occupational hazards, needle prick by the practitioner, then dialysis units, surgical intervention, exposure to the patients repeatedly, then body piercing, that is a infected person infected needle using for the tattoo for the non-infected persons, then shared razors, shared toothbrushes. Ingestion of raw shellfishes can also contribute some of the hepatic disorders. Medication history and some vitamins, alcohol history in detail, CAG symptoms are can also be considered. History of other disorders, reduced urine output, altered consciousness, confusion, and contact with rats or some of the biting with cats, rats, dogs, or pet animals. The CAGE can also having cut down of symptoms, annoyed, guilty, and eye opener that can be comes under CAGE symptoms in our clinical practices. After knowing the thorough history, a practitioner should do examination as a compulsory part. First and foremost is pallor, ectrex sclera, then skin mucosa must be examined very thoroughly, wasting of muscles, skin excoriations, needle tracks, petaches, breathlessness, muscle weakness, spider angiomata, palmar erythema, gynecomastia, parotid enlargement, testicular atrophy, reduced body hairs, hepatosplenomegaly or organomegaly, ascites, spider navy, abdominal distension, tender abdomen, dull abdomen, palpable liver and gallbladder, tremors, confusion, disorientation, then fatal hepatitis. These are the conditions where the patient comes with our clinical practice of pertaining to hepatobiliary system, from pallor to the fetal hepaticus. This is how the patients will be presenting with the exam, what the person has to do proper examination. After this, LFT start function. So liver function test are the test to know, to assess the functions of liver. Rather than this, we can say pathological condition of the liver can be understood. So it is misnomer. It is compulsory to understand the proper way of liver function test. A battery of test which includes total bilirubin, direct bilirubin, indirect bilirubin, SGOT, SGPT, ALP, GGT, 5NT, total proteins, albumin, globulin, albumin globulin ratio, and prothrombin time. These are the very important contents of liver function test. So we will discuss in detail what is the contents. So why LFT is compulsory? To detect the presence of liver disease. It may be yes or it may be no. For the screening purpose, it may be no, and for the disease purpose, definitely it is yes. So to detect the presence of liver disorders, to measure the extent of severity of liver disease. Cirrhosis of liver, mild, moderate, and severe. Fibrosis of liver, mild, moderate, and severe. Acute hepatitis, mild, moderate, and severe. To detect the pattern of liver abnormality or to distinguish among different types of liver disorders. So if it belongs to hepatocellular or cholestatic. To identify specific cause, it may be viral hepatitis, obstructive hepatitis, hemolytic hepatitis, or toxic hepatitis. To investigate possible complications, bleeding disorders because of lack in the prothrombin or hepatic encephalopathies. Last one, to follow up response to treatment. The content of the liver function test which are raised, they are in reduction stage or the values are in elevated, which are used to be monitored. This is the very important content what we must know from the liver function test. So classification of liver function test, there are three major classification. One is test based on excretory function, bilirubin and bile salts. Test based on serum enzymes, AST, ALT, ALP, and GGT. Test based on synthetic activity, proteins, and prothrombin. These are the very important functions what liver performs in our day-to-day practices. Then first and foremost thing is bilirubin. It is a major source of bilirubin from the RBC. So the graveyard of RBC is spleen. There is a breakdown of RBC, destruction of RBC as the days progresses because of 120 days. Then there is a release of hemoglobin. The globin part is as a protein which is reabsorbed in the reutilized, and the heme content. Heme is oxygenated. Again biliverdin reductase. Bilirubin comes. Then bilirubin lipid soluble in nature. This bilirubin will make unconjugated bilirubin that enters the liver. Prior to this, there is a unconjugated bilirubin. If anything happens from spleen to entering of the our liver system, that is belongs to the reticuloendothelial system called unconjugated hyperbilirubinemia. From this content, transportation of liver from unconjugated bilirubin to the transportation to the liver, there it becomes conjugation. It becomes conjugated bilirubin. Then it is water soluble in nature that transports into the intestine, starts bacterial action. Then it makes urobilinogen, which also breaks down in the stercobilinogen. Again reabsorbed among 80% go to the stercobilinogen, again reabsorbed in the liver 18%, and only 2% go to the urine for the coloring of urine to the urinobilinogen. So this is how only in our generally there is a 250 to 300 mg per day there is a secretion of uh, bilirubin in the blood, bilirubin from the liver. But as a practice, as a condition, we should know only 1 mg is present in the blood there. This is the most important notice what we must understand. This is how the bilirubin physiologically works in our day-to-day life there. If generally, what pathophysiology takes place? Destruction of RBC in uncontrolled manner, that where the pathology is there, that is called uh, prehepatic hyperbilirubinemia. Second one is that is splenic condition. There is a more the amount of destruction of RBC. Second one is in the liver directly there is a mixed presentation, and the third one is post-hepatic. So this is how the prehepatic jaundice, unconjugated hyperbilirubinemia. Then hepatic jaundice, mixed hyperbilirubinemia. There is chance of prehepatic or conjugation or conjugation. And lastly, post-hepatic jaundice or conjugated hyperbilirubinemia. That is predominantly conjugated bilirubin is present in the blood there. So this is the major pathophysiology of liver, what we should understand. Then what is bilirubin? Bilirubin, there are two versions. One is unconjugated and conjugated bilirubin. So or direct or indirect. So unconjugated bilirubin is present normally in plasma. Unconjugated bilirubin is present normally in plasma because it is not entered into the liver. But conjugated bilirubin, direct bilirubin is present in bile because it is entered into the liver system. Unconjugated bilirubin entered binded with albumin because it is protein. But conjugated bilirubin conjugated with glucuronic acid. Unconjugated bilirubin is insoluble in water, but it is fat soluble and alcohol soluble. Conjugated bilirubin soluble in water, insoluble in fat and alcohol. Toxic to the tissues, that is unconjugated bilirubin. Non-toxic to the tissues is conjugated bilirubin there. Mild rise in hemolytic jaundice because it is prehepatic, before entry of hepatic system. But in case of conjugated bilirubin, marked rise in hepatic and obstructive jaundice because pathology lies in the liver or post liver. Normally 0.1 to 0.6 mg per day present in blood, but this is normally conjugation is normally 0.1 to 0.4 mg per day in the blood. So differentiate unconjugated hyperbilirubinemia. Prehepatic jaundice is present due to hypersplenism, hemoglobinopathies, that is plasma disorders, protein disorders, hereditary spherocytosis, enzyme deficiency disorders, malaria, and hemolytic disease of newborn. In case of conjugated hyperbilirubinemia, that is due to hepatitis because the pathology is present within the liver. Because of hepatitis, cancer of liver, cholestasis, intra and extrahepatic, cirrhosis of liver, choledo cholelithiasis, and cancer of head of the pancreas. Because cancer of head of the pancreas that obstructs the secretion of bile juice. So this is how the unconjugated indirect, where there is an increase in indirect bilirubin, we must understand. Where there is an increase in direct bilirubin, we have to understand. So there is a basic difference of bilirubin in our blood, LFT. Then hyperbilirubinemia, unconjugated hyperbilirubinemia, intrinsic and extrinsic causative factors of RBC because of breakdowns. There is bile overproduction, impaired bile uptake, and impaired conjugation. This is the only increase in the hyperbilirubinemia. AST, ALT, ALP, GGT, and albumin all are normal in level. But conjugated hyperbilirubinemia, hepatic and extrahepatic cause. In case of unconjugated hyperbilirubinemia, intrinsic and extrinsic causes of the RBC because of their breakdown. But conjugated hyperbilirubinemia, hepatic and extrahepatic causative factors. Their decreased excretion into bile canaliculi, as we discussed in the anatomy of the liver, and a backward leakage due to obstruction. There is a regurgitation of bile juice towards the liver that causes conjugation hyperbilirubinemia, where elevation of AST, ALT, and ALP. But indirect bilirubin is less in case of unconjugated hyperbilirubinemia. So mixed hyperbilirubinemia is present in hepatocellular jaundice. Unconjugation prehepatic, conjugation posthepatic, mixed that is hepatocellular jaundice. This is the three basic difference of hyperbilirubinemia. Then liver enzymes are basically protein enzymes which catalyze reactions located in the different parts of hepatocytes. Degree of elevation of enzymes depends on pattern of hepatic damage. There are basically two types: enzyme that indicate hepatocellular damage, enzyme that indicate cholestasis. So this is a major enzymatic action of the liver. So there are enzymes ALT or ALAT or SGPT, AST, ASAT or SGOT, ALP, GGT, and 5-NTs. We discussed what are the SGOT, SGPT, ALP, GGT, and 5-NTs. So this is how, see the picture shows this is how the alanine phosphatase, gamma glutamine phosphatase, and alanine aminotransferase. These are the content where enzymatic actions are the carried out in the liver anatomies. So serum transaminases enzymes catalyze transamination reaction between an amino acid and keto acid, important in synthesis of amino acids and thus proteins located in the liver, muscles, cardiac muscles, etc. They are also having transaminases not only in liver, muscles and cardiac muscles are also contribute increase in the liver functions. Sensitive markers of acute hepatocellular injury, normally very low levels serum in the serum. In case of tissue damage, they are released into blood, thus their concentration increases. That's why there is increase in the increase in their concentration in the blood there. So SGOT, SGPT are the main source of enzymes there. So what is SGPT? Alanine transaminase or alanine amino transaminase serum glutamic pyruvic transaminase. So SGPT, we can say PT and OT. So cytosolic enzyme found in the various body tissue, most commonly in, especially in liver, normally 0 to 40 interest per liter. It is increased, the SGPT is increased in case of viral hepatitis, acute hepatitis, hepatocyte damage, congestive cardiac failure, myopathies, and some of the drugs there. SGOT, aspirate transaminase AST or ASAT, aspirate amino transaminase or serum glutamic oxaloacetic transaminase. SGPT and SGOT. So found in various body tissues, liver, heart, skeletal muscles, kidneys, brain, pancreas, lungs, and RBCs. Cytosolic and mitochondrial enzymes in hepatocytes, normally 0 to 40 international per liter. Raised AST, where SGPT is raised, where SGOT is raised. Hepatitis, myocardial infarction, acute pancreatitis, burns, acute renal failure, trauma, hemolytic anemias, musculoskeletal disorders. These are the conditions where SGOT is raised. SGPT are more specific indicator of hepatic inflammation than SGOT. If there is a raised SGPT, there is a conclusory marking of hepatic inflammation, hepatitis, rather than SGOT or AST. AST-ALT ratio, that is SGPT-SGOT ratio, normally 0.7 to 1.4. Increased ratio of more than 2 is highly suggestive of ALD, alcoholic liver disease, alcoholic hepatitis. In very early acute viral hepatitis, AST is more than ALT, enzyme activity 7 is to 3. But as a time progress, ALT is more AST within 24 to 48 hours of infection. As it becomes chronic, AST increases rather than more than ALT, because due to necrosis of the liver function, mitochondrial damage of the liver, and cellular destruction. In chronic hepatitis, ratio of AST is more than 1% rather than ALT. This is the SGOT and SGPT must be understood. So in case of alcoholic hepatitis, ALD, AST is comparing, SGOT is comparing to the 3 or 4 is to 1%. That should be kept in mind. So acute hepatitis, the AST is always lesser than ALT. That is SGOT is less than SGPT. Elevation of transaminase. This is how we have to understand. The graphical representation will brings our notice that how there is an increase in the transaminase or the enzymes. See, normally we expect up to 40 international units per liter in our bloodstream. If it is more than 40 to 100 or 200, can be considered as chronic hepatitis. If it is more than 300 to 1000, alcoholic hepatitis. If it is more than 3000 to 5000, considers acute viral, or 2000 to 4000 condition acute viral hepatitis. If it is more than 5000, then toxic or ischemic injuries. In case of liver cirrhosis, there is a chance of less or subnormal secretion of enzymes. Normal or subnormal secretion of enzymes in the liver cirrhosis. This is the representation or understanding of how there is a elevation of enzymes takes place in the LFTs. So what the graphical representation takes place, market elevations more than 15 times the normal in case of viral hepatitis, toxic hepatitis, necrosis due to ischemia, that is congestive cardiac failure. Moderate elevations 5 to 15 times than the normal, chronic hepatitis, autoimmune hepatitis, drug induced hepatitis, or acute biliary obstructions. And lastly, mild elevations 1 to 3 times than the normal, liver cirrhosis, chronic alcoholic steatosis, or cholecystitis. This is how the graphical representation of previous slide must be understood. Important in the differential diagnosis of hepatocellular jaundice from cholestatic jaundice must be understood. This is the, because in case of massive liver necrosis, there is a chance of increase in the enzymatic action. So next one is ALP, alkaline phosphatase, is the collective name given to a group of enzymes that catalyze hydrolysis of large number of organic phosphate esters in an alkaline pH. Found in various tissues, liver, bone.
Sorry to disturb you.
Well,
Sorry to disturb you, Dr. Kishore. Your voice is becoming a bit low. I think there's a problem with mic. You can hold it nearby.
okay, okay. Sorry, ma'am.
Yeah, yeah. Now it's clear.
Yeah, ALP, alkaline phosphatase, is the collective name given to a group of enzymes that catalyze hydrolysis of large number of organic phosphate esters in an alkaline pH, found in various tissues, liver, bones, intestine, kidney, and placenta. in liver located normally in canalicular surface of hepatocytes. Then and biliary canaliculi, hepatic sinusoids. Normally 25 to 120 international units per liter. See, this is how there is a ALP secretion will takes place. Alanine phosphatase, as we shown in the last that is the slide. From here there is a secretion of ALP, that is alkaline phosphatase enzyme. Then this there, is there any deformity in case of canalicular surface hepatocytes or biliary canaliculi that leads to cholestatic jaundice or infiltrative liver disease, that is called liver cirrhosis or the liver cancer. So less than 3 times normal in an abnormal level, non-significant, non-specific. The raised ALP, that is raised ALP, is observed in case of cholestatic jaundice more than 3 or 4 times. That is in case of primary biliary cirrhosis or cancer of liver or cholangitis. In case of if patient is non-cholestasis, that can be observed. If you go to the flow chart, first one there is a cholestasis, then accumulation of bile acids, dissolve canalicular sides of hepatocytes, release of ALP, rise in ALP. So that makes extra hepatic. This is how there is a, as we see, this is the condition where the alkaline phosphatase, which is releasing in the our liver cells, that is function of the liver due to enzymatic action. If it is disturbed, that makes what, there is a cholestasis due to in case of cholestasis, that will make accumulation of bile acids, dissolves canalicular side of the hepatocytes, then release of ALP and makes raise in ALP, more the amount of ALP. This is a condition where ALP will be raised in case of primary biliary cirrhosis, CA liver, and cholangitis. Other than liver, there is a chance of a raise in ALP in bone disorders, increased osteoblastic activity as an osteomalacia, rickets, hyperparathyroidism, Paget's disease, and osteosarcoma. Also, in a primary hyperthyroidism, Hodgkin's lymphoma, and polycythemia vera. In case of other cancers like bone cancer, breast cancer, colonic cancer, and lung cancer, pancreatic cancer, also there is a raised in ALP. If is an increase in ALP, look for gamma glutamine transpeptidase and 5-neutron condition, because cannot distinguish between intra and extra hepatic cholestasis. So the practitioner should look for GGT and 5-NTs. So what is GGT? Gamma glutamyl transferase or gamma glutamyl transpeptidase. It is a microsomal enzyme found in cell membrane, cell membrane of many tissues like pancreas, intestine, heart, and kidneys, prostate, spleen, prostate, spleen, brain, seminal vesicles, and epididymis. Not, notably in liver, biliary epithelial cells, and canalicular surface of hepatocytes as an LLP, as we discussed in last slide. Normally 0 to 40 international unit per liter. Raised GGT, especially in alcoholism and cholestasis, as we discussed in the last slide, hepatitis, and also in drugs, some of the NSAIDs. So GGT always makes the GGT always makes the raise in case of alcoholism, cholestasis, hepatitis, and also in some of the drugs like NSAIDs. GGT has better sensitivity than ALP in biliary tract disorders. If ALP can't conclude, there is a blockage in the biliary tract, then definitely the GGT will give a better confirmation regarding the biliary tract disorders. Then alcoholism is the more very important aspect to note the increase in the GGT. GGT not elevated in bone pathologies. In previous slide, there is a, other than tissue, other than liver pathology, there is a bone disease also in disorders there that increases the ALP. But in case of alcoholism, the GGT very not get elevated. 5 nucleotidase, second point. enzyme located along the canalicular and sinusoidal cell membrane of hepatocytes, similar to the ALP and GGT, normally 2 to 17 units. Then raised 5 nucleotidase is obtained in cholestasis, hepatitis, hepatic injury, liver ischemia, liver cancer, during pregnancy, and drugs. More specific to the liver, more specific to the liver, and that is advantage over ALP. If ALP is present in the liver, then there is a disadvantage in the ALP presence in the liver. So plasma cells in cirrhosis and chronic active hepatitis, serum levels of gamma globulins are produced against the intestinal bacteria as a cirrhotic liver fails to clear the bacterial antigens which reach liver through portohepatic circulation. Albumin globulin ratio normally found 1.5%, but reversed in case of liver cirrhosis and chronic hepatitis due to fall in albumin level. The decreased synthetic activity of liver and raise in globulin levels due to increased inflammatory activity. Globulins are increased due to inflammation of liver. Albumins are increased due to not directly in the hepatic and acute hepatitis, but in the chronic hepatic conditions. The prothrombin time, most coagulating proteins in clotting factors are synthesized in the liver. Vitamin K dependent factors, factor 2, factor 7, factor 9, and factor 10. The prothrombin time measures 2nd, 7th, and 10th. The synthesis is deficient in hepatocellular jaundice. Vitamin K is not absorbed in obstructive jaundice. So prothrombin time is prolonged. Why there is an increase in the prothrombin time? Because in case of obstructive jaundice, there is no proper absorption in the vitamin K there. Prothrombin value is 10 to 15 seconds. The prothrombin time value is 10 to 15 seconds there. So the differential diagnosis is vitamin K injection must be gives the differential diagnosis there. Let us discuss some few cases there. Case study for hepatitis, history, the travel history or sexual contact, treatment, unfortunately enter the hepatic conditions, and then alcohol, symptomatology, fever, fatigue, pain abdomen, nausea and vomiting, examination, sick look, tender liver and ectris, laboratory investigations, mixed EST and ALT were present, Usually recovery hepatitis A, chronic hepatitis B, hepatitis C, and hepatitis D will be delayed recovery. Complications observed through hepatitis B, C, and D. So there is a chance of viral hepatitis, toxic hepatitis, drug-induced or autoimmune hepatitis there. So causes of alcohol maybe case study. Second one is cirrhosis of liver. First and foremost cause is alcohol, fatty liver, chronic hepatitis B and C, Wilson's disease, then autoimmune hepatitis. Symptomatology like chronic jaundice, weight loss, abdomen pain, abdomen distension, intense nausea. Signs jaundice, ascites, palmar erythema, spider angioma, splenomegaly, tremors, prominent veins there. Long-standing alcohol patients start tremoring because of liver pathology. Diagnosis first and foremost is biopsy, decreased albumin production, increased bile salts and prothrombin time, increase in globulin secretions, and we have to go for radiology investigations. So this is the abdomen distension, palmar erythema, and spider angioma. The second one, third one is obstructive jaundice, history, gallstones, pain abdomen, weight loss, causes impacted gallstones, as patient said, or maybe worms, growth in the biliary tract or head of the pancreas. Symptomatology, pain abdomen, intolerable itching, weight loss, pale stool. Signs, greenish yellow sclera and mucous skin. As we discussed, obstructive jaundice, that is Shakashata Kamala. Diagnosis can be done with increasing conjugated bilirubinemia, increased ALP, and increased gamma glutamate transaminase. You have to go with USG and ERCP. This is a mass. Then see, this is how they go for ERCP investigation. The ERCP is the gold standard investigations for the diagnosis of obstructive pathology in the liver. There. Fourth one is cancer of the liver. Third leading cause of death. Risk factors hepatitis B and C, cirrhosis of liver, obesity, aflatoxins, then tumors of the abdomen and pelvis, symptomatology, weight loss, jaundice, pain abdomen, abdomen mass, vomiting, fever, and fatigueness. Diagnosis can be done with USG, CT, EFP, it is alpha fetoprotein, then biopsy. Let us interpret the few lab reports. Left is, see, there is a total bilirubin, then direct bilirubin, indirect bilirubin, ALT, total protein in serum globulin, SGOT, SGPT absolutely normal. Then there is a decrease in the hemoglobin. This indicates hyperbilirubinemia. That is unconjugated hyperbilirubinemia. Enzymes are a normal, low HB. That is the conclusion factor of hemolytic jaundice or pre-hepatic jaundice. This is the first case what I have shown in the third or fourth slide. Then second one, biochemical analysis. See, bilirubin total and direct bilirubin is absolutely heading normal. Then SGOT and SGPT, they are markedly raised. What the graphical representation indicates, there is markedly raised. Then hyperbilirubinemia, which is predominantly conjugated hyperbilirubinemia. Then severe raise in transaminase, AST is lesser than ALP, ALP, GGT condition, then there is a, as we discussed in the slides, acute hepatitis there. Then third presentation, see the serum total bilirubin 6.56, then serum asparagus, SGOT and SGPT 20 and 30, serum alkaline phosphatase ASP 67. So that indicates the hyperbilirubinemia. It is unconjugated hyperbilirubinemia. Normal HB is present, normal enzymes. So it is Gilbert syndrome. Simply patient start goes on breaking the RBCs. So last one, that is 8.7 total bilirubin, but ALT, SGOT, SGPT are increased. So hyperbilirubinemia, predominantly conjugated hyperbilirubinemia, severe rise in transaminase enzymes, AST is lesser than ALT, low ALP, that is the classical presentation of acute hepatitis. So this is last presentation of this report. So total bilirubin 13.3, direct bilirubin 11, serum albumin 3.4, globulin is 4.2. That indicates the hyperbilirubinemia. That is bilirubin is raised. That is predominantly conjugated. That is direct bilirubin is raised there. Abnormal AG ratio, albumin globulin ratio 40 is in. See, that is there. Then raised transaminases and other enzymes. That is the chronic hepatitis. So this is what we can see in a report there. So last one, total bilirubin is 0.8, direct bilirubin is 0.3, very normal in bilirubin levels. But ALP is severely raised. That is the cause of extra cost, that may be chance of a bone or other disorders also. So other investigations has to be carried out. Alpha fetoprotein, ferritin, then seroplanism, then ANCA, AMA, IgM, ANA, anti-nuclear antibodies, IgG, anti-HIV, anti-HCV, anti-HDV, and anti-HEV, HBsAg, and these are the also investigations can be monitored other than the LFTs. LFT shortcomings are is a lack of sensitivity and very specificity, may be absolutely normal in serious liver injuries, but we have to identify the early stage of infection can be very easily diagnosed, may be abnormal in patients with the disease that do not be affect the liver, because others other than liver pathology can also be diagnosed. So thus jaundice occurs as a result of excess production of bilirubin, then impaired hepatic uptake of unconjugated hyperbilirubins, then impaired conjugation of bilirubin, and last one is decreased excretion of conjugated bilirubin. So what is the condition to understand the liver function test? AST ALT is very important. So liver is the during liver pathologies, hyperbilirubinemia is not specific to any pathology, because there is a chance of unconjugated hyperbilirubinemia due to reduction in the blood the destruction in the RBCs. Conjugated or unconjugated or mixed may be give clues towards pathology of liver. Serum transaminases always depict hepatocellular pathology, that is SGPT and SGOT. Their level may raise indicate the specific illness, and SGOT SGPT ratio also. ALP, GGT, and 5-nucleotidase are specific to biliary tract and depict cholestasis obstructions. Albumin indicates the synthetic function of the liver reduced in chronic hepatitis. Albumin also stored in the liver system. Then prothrombin time, it is a prognostic evaluation, and also the practice has to evaluate USG, CT scan, radiological modalities, and other blood tests which are useful for the liver function test. So I thank one and all for the giving me opportunity. Thank you one and all. If any questions, please you can ask.
Thank you so much, Dr. Kishore. It was really exhaustible and
And
very
one more
wonderful.
one more point, within